Good evening, everyone, and welcome to CornerStones Best of DDW in IBD 2022 for Australia Part 1 webinar. I'm happy to introduce tonight Professor Susan Connor and Associate Professor Miles Sparrow, who will be bringing you our Best of DDW program.
Okay, so diagnosis, prognosis and prevention. We've just got two studies that we're going to present here, both of which are just summaries of a multitude of studies from in these sections. And I'm just going to present this really as take-home messages on these 6 studies you can see here are presented. The bottom line is in the title here is that the epidemiology of IBD is changing globally. Overall, there is an increase in incidence and therefore prevalence globally. It does appear that in Western developed countries, perhaps there is a plateauing, whereas in developing countries, there is still an increase in prevalence. If we go through these studies, looking at a take-home message only for each one. Study number 1 was by Jim Lewis from Pennsylvania, where they looked at 3 databases, which included some government databases, Medicare and Medicaid, and also an insurance claims database. This is the first study that has shown a prevalence of IBD in the US of 1%. In most very high prevalence areas, we see numbers of sort of 1 in 150 to 1 in 200. This was 1 in 100 for the first time shown in the US. I do think claims database studies that are using coding for diagnoses do have some flaws, but interesting results nonetheless. If we go down below to the study from Olmsted County in Minnesota, this is a group that's had a very long and rich history in epidemiology led by Ed Loftus. This was a study that showed actually 5 decades of incidence and prevalence data, and they showed that there has been a steady increase in the incidence of both Crohn's disease and ulcerative colitis until the last decade, in which case there's actually been a slight reduction and a plateauing effect. If we look at the bottom 2 studies, numbers 3 and 6, which we've grouped together, number 3 is Western Europe. This is in Denmark, and we can see that there's been a significant increase in prevalence of both Crohn's disease and ulcerative colitis epidemiologically over this almost 25-year period. If we look at this study from Vestrum and West Hungary at the bottom on the right, so we're now looking at Eastern Europe, there's a dramatically increased both incidence and prevalence of IBD in Eastern Europe here. I'm not quite sure to what to make of these numbers because they're really an order of magnitude different to other incidence and prevalence studies. But I think what we're seeing is there is still an increase in Europe, especially in Eastern Europe. A really interesting study looking at the top right here from Rupa Banerjee's group from Hyderabad in southern India on 15,000 South Indian patients who had colonoscopies. This was the first study that has ever shown a higher prevalence of IBD in India versus infections, and in particular tuberculosis and amoebic colitis. The other thing that was interesting and perhaps a little bit daunting here, most studies have shown an urban to rural divide where IBD is a lot more common in urban regions. This didn't show that. So there was an equal prevalence in rural regions in India. And then the final study from New Zealand showing over the last decade an overall increased prevalence in IBD in New Zealand, but especially a 46% increase in their Indigenous Maori population. I think lots of interesting data here. What we're going to, as a global IBD community, work out how to do is the economics of treating these enormous numbers of increasing numbers of patients, especially in developing countries. Some further epidemiology data now looking at risk and protective factors associated with IBD. The way to look at this side, the purple are potential risk factors for developing IBD, the blue are potential protective factors. These are again take-home messages. Really interesting, and I'm starting here at the top left on mebendazole. A study, there's an ongoing collaboration between Mount Sinai, led by Jean-Fred Colombel, and some of the Scandinavian countries who have these beautiful population-based databases. The question that they asked here was, does routine worming of populations increase prevalence of IBD in adulthood? And what they did find is that there was an association of receiving mebendazole as an anti-worming agent at an age of less than 5 in early childhood was associated with an increased risk of adult onset of ulcerative colitis, perhaps fitting with this hygiene hypothesis. If we're not exposing babies and infants to microbes and parasites, there is perhaps an increased risk of developing IBD later in life. The data at the bottom are from Charles Bernstein's group in Canada. There has been an association, not a strong one, but it is recognised between allergic conditions and IBD, asthma and allergic rhinitis. But what this study demonstrated was actually that the development of asthma, allergic rhinitis and hay fever first can subsequently be a trigger for developing IBD later. So these allergic conditions were diagnosed first, and then there was a peak of developing IBD later, suggesting some sort of immunological triggering that may be occurring. An interesting study, top in the middle here on antibiotic exposure. I think we've been aware that there is an association between antibiotic use, especially in childhood, and the development of inflammatory bowel disease in childhood and young adulthood, predominantly in Crohn's disease. These were data from Denmark, again by the same group, Mount Sinai, but using this Scandinavian data that showed an increased association with the development in IBD and antibiotic use in adults. And they actually looked at the group that were over 60 years old. So the things that were novel about this study, it was adults, not kids, and the association was seen for both Crohn's disease and ulcerative colitis. It was pretty convincing data in that there was an exposure response effect, in that the more antibiotics patients received and the closer it was to their diagnosis, the stronger the association. And the antibiotics with the strongest association were those that affect the gut microbiome, that is the fluoroquinolones and nitroimidazoles. So I think the message here for us is, really, especially if patients have got other risk factors for IBD, really being very cautious about antibiotic use, only use them when they're really needed. EBV at the bottom here in the middle, our main concern to date with EBV has been the risk of thiopurine-induced lymphoproliferative diseases in EBV positive patients, or the development of this horrid, rapidly progressive lymphoproliferative disease if patients develop EBV for the first time. This looked at actually EBV as a potential etiological factor in IBD, which hasn't been shown before. So these were from actually 3 cohorts. There was Jean-Fred's military cohort that he's looking at, where he's got Syria that dates back a couple of decades before the diagnosis of IBD. There was another small institutional cohort, and then there was actually the GEM project, which we'll see some other studies from, which is this big global genetics, environment and microbiome epidemiological cohort. And what they showed actually in all of these 3 cohorts was that there was actually an increased prevalence of EBV prior to the diagnosis of Crohn's disease. So prior to any therapy, nothing to do with that. So perhaps suggesting an etiological role of EBV, obviously at this stage just showing association, but no way of being able to prove causality. It'll be interesting to see how that question evolves. The top right, some disturbing data from the Nurses Health study that's been analysed for a number of questions from the group at Mass General in Boston. They showed, that psychosocial stressors in young adulthood, and in this case, severe child abuse, both physically or sexually in women, did have an association with the development of Crohn's disease in adulthood. Pretty disturbing data there. Maybe finishing with some good news, the possible protective factors. You can see these are both from the GEM study. This is a big global study. It's actually based out of Canada, but there's a lot of European cohorts and some in Asia Pacific as well. What they showed, presented to some humour, but made good sense, was that at the bottom you can see living with a dog as a kid is protective against developing Crohn's disease. If you have a dog in your family when you're kids are aged 2 to 4. Another good reason to get a dog, I think, again, probably fitting with the hygiene hypothesis. And then a similar take of being in a large family, having a lot of kids, a lot of bugs, family size of greater than 3 in the first year of life was actually protective against the development of Crohn's disease. That's the end of the initial epidemiology section, and I'll move on to small molecules. There's a question here I'll just jump to from Tuan Dung on subcutaneous infliximab. And the question here is and I'll just address this briefly, Tuan, now, because we'll cover this study in detail tomorrow. In regards to subcutaneous infliximab, do you modify the doses for patients with high BMI? Simple answer is no. There are some pharmacokinetic studies that do show that the overweight patients have slightly lower drug levels, don't do quite as well, but it's nowhere near as pronounced as for perhaps the other subcutaneous anti-TNFs. So I think the simple answer there is no. Everyone gets the 120 alternate weekly dose. We'll go into that study in more detail tomorrow night when we're looking at biologics. Please send in your questions. I'll look at them at the end of each section. Going to move on now to a really important section of current and emerging therapies, non-biologics, which is predominantly small molecules. We've also got some dietary therapies here as well. We've reached and we're going to continue to expand the era of small molecules and a return to them. I'd suggest that in the next 12 months, we may have access to up to 3 new small molecules: Ozanimod, the S1P modulator, and then the JAK inhibitors, upadacitinib and possibly filgotinib. Small molecules progress in their development programs faster in ulcerative colitis and Crohn's disease. That's when we'll have access to these drugs first. And we need to know how to use them. We've got some new data here. We've got some post-hoc analyses of relevant clinical questions, and then some other non-small molecule therapy. Starting with what we've got though in tofacitinib, we're all aware that, and I think as a generalization, with small molecules, the issue is not efficacy, it's safety. These drugs work very well, the different classes. They have off-target effects. They act intracellularly, they hit multiple pathways, and these off-target effects and side effects have emerged. And with tofacitinib, what has been shown is this association, in particular with thromboembolism, but also with MACE, major cardiac events. Now, this has led to a black box warning on this drug in the US, and there are prescribing restrictions that it can only be prescribed after anti-TNFs in the US. Thankfully, that's not the case here. I think we need to put this into context. The first thing to say is these signals have only been demonstrated in rheumatoid arthritis patients. We are now out to nearly 8 years of follow-up in ulcerative colitis with post-marketing surveillance from the OCTAVE studies, and we're not seeing an increased signal of thromboembolism. We are seeing one of zoster. But the other thing is it's also only with the higher dose. It's 10 milligrams twice daily. And I'm sure you're aware, but the rheumatological patients where these thromboembolism or MACE were seen had other cardiovascular risk factors. They were over 50, and in the study where the anti-TNF was the control, they had other cardiovascular risk factors. But what we need here is more data and more numbers. This is a relevant issue that we have to tell our patients. It's a watch this space at this stage. So in a clinical trial, your numbers are always going to be relatively small. I think from memory, the OCTAVE studies were maybe 800 or 900 patients. What you do need to do is you need to go to some big population databases. So this is an analysis from a US claims database done by Ashwin and Antha Krishnan from Mass General in Boston. I mentioned before, claims databases have got their flaws in coding for diagnosis, both for IBD and for thromboembolism, but they looked here to get some good numbers on what are we seeing at a bigger level about these risk factors. They matched 305 patients on tofacitinib to almost 20,000 on anti-TNFs. You'll remember that the initial rheumatology studies, the control group was anti-TNFs, and they looked for VTE, thromboembolism and MACE. As is become the norm with observational studies in IBD, they did propensity score matching, which is matching patients for demographics, for phenotype, for other treatments, etc. If we look at the results over on the right here, we can see this is encouraging. There was no significantly increased incidence of either thromboembolism or cardiovascular events, including MACE, between tofacitinib and anti-TNF treated patients. And overall, the risks of these were low. I think these data aren't definitive. I think they're encouraging. Ongoing post-marketing surveillance within our ulcerative colitis programs, I think, will be necessary. But so far, these data are looking encouraging. Another tofacitinib study, and one of the questions we've got with this availability of more therapies, is where do we position them? This data, which is a multi-center study from France presented by Anthony Buisson, looked at patients who'd failed one biologic that must, at least one biologic, and it must have included at least one anti-TNF, and it was predominantly an anti-TNF failure cohort. These are an ulcerative colitis study. Remember, we've got tofacitinib for UC, not for Crohn's disease. And they asked the question, who does better as a second therapy if you give them tofacitinib or if you go to vedolizumab as another biologic? Again, these are retrospective data with all those flaws, but it's multi-centered. The numbers are pretty good. They did propensity score matching. The primary endpoint was steroid-free remission at week 16. And they looked at endoscopic outputs. That's a pretty early endpoint for vedolizumab, but still the numbers are good here, about 300 patients, and you can see the results here on the top right. There was no statistical difference between these two agents, tofacitinib or vedolizumab, a slight numerical advantage for tofacitinib, but when they did their multivariate analysis and some other post-hoc analyses, there were some scenarios in which tofacitinib was favourable, and that was in patients who'd failed multiple biologics, at least 3, or in patients who'd had primary failure to their initial biologic, remembering this is predominantly anti-TNFs. I think the message here for us is, with progressive use of biologic therapies, there is a law of diminishing return. I think a really interesting one would be, if you flip this around, what about if their first biologic was vedo? I think maybe in that case, we might even see more favourable results for tofacitinib. We've got to learn how to position the small molecules, especially in ulcerative colitis, in relation to biologics. I think there'll be some patients in whom we might want to use them first line. That's probably mainly going to be young patients who want an oral therapy. There'll be other patients in whom we will want to try other biologics first, but perhaps where they seem to be slotting in is after we fail our first biologic. That's a big generalization. We need some more data on this. We're going to move now to some of our newer small molecules, and upadacitinib. So upadacitinib is AbbVie's molecule. It is a JAK1 selective and what's termed reversible, which just means a short half-life molecule that is proving to have very effective results in both ulcerative colitis and Crohn's disease. What we're looking at here, and what we've learned from tofacitinib, and there's a couple of messages that come out in this slide set about small molecules in general, is that there's a significant proportion of patients who need longer than the usual induction therapy to respond. We shouldn't give up too early, but also, given these are small molecules and not biologics, they don't induce immunogenicity, and we can retreat with them. So what we're looking at here is the upadacitinib in ulcerative colitis data. The development program here was the UAchieve induction and UAccomplish studies for both in 2 separate induction studies. For upadacitinib, the other thing with JAKs we've got different doses, unlike biologics where we get the same dose. So the doses here, the induction dose is 45 milligrams and the maintenance doses are 30 milligrams or 15 milligrams. The induction period was 8 weeks, which is the same as it was for tofacitinib in Octave. The question that they asked here is, what about the patients that don't respond to 8 weeks of therapy if we give them another 8 weeks, i.e. 16 weeks all up? So the overall induction program was about 900 patients, of which 125 received an additional 8 weeks of therapy. But what you can see here is almost half of them, 48% of patients responded. The message here with small molecules, I think as a generalization with any therapy, is don't give up too early. There's a significant proportion of patients who need longer for induction. Then that they looked at, so that's the results at the top, then that they looked down at the bottom, and of the patients that responded at 16 weeks, there was a signal to a better response at 52 weeks with the 30 milligram dose versus the 15 milligram dose. Not all of those differences reaching statistical significance. Message here is just, don't give up too early. An important question that we ask ourselves as clinicians when choosing when to position a therapy, be it a biologic or a small molecule, is what about extraintestinal manifestations? And does the patient have them? Do our therapies respond? This analysis of the same data set was looking at EIMs out to a year, and these were recorded at each study visits, asking the question, does upadacitinib work for these? So of the total patient population in induction, there was about 160 patients who had an EIM, and in maintenance it was about 80. What they did for the EIMs, they grouped them. So the results, if we look here over on the right, week 8 is induction, week 52 is maintenance. They grouped resolution of any EIM together. Then they looked at what I think is the most important one, is arthropathy, and then they looked at anemia. Personally, I think anemia is a complication of disease, not an EIM. You can see at 8 weeks at an induction, there was a numerically greater response for upadacitinib to placebo for any EIM, arthropathy or anemia, but not reaching significance. But out to a year, it did. And so out to a year, and especially I think it's in the middle here at the bottom, looking at arthropathy, which I think is our most troublesome EIM, we can see a significantly greater response rate just with the 30 milligram dose, not the 15 milligram, didn't reach significance for EIMs with this molecule. I think that's really nice data. It's encouraging. And in general, the JAKs are a systemic therapy. So it makes sense, doesn't it? I don't think this is molecule specific, but it's nice to have demonstrated it with this new agent. What about some Crohn's disease data? As I mentioned, the development's further ahead with ulcerative colitis. This molecule, upadacitinib, is looking really encouraging as a JAK inhibitor for Crohn's disease. So here we've got we're just out presenting induction data, so out to week 12. This was a phase 3 double-blind study, again using the same dose as 45 milligrams for induction. This study had a mandatory steroid taper at 4 weeks, so these results are steroid-free results, as really they all should be. Looking at co-primary endpoints of clinical and endoscopic remission at week 12, if we turn to the results up on the top right, you can see a really nice delta between drug and placebo at induction for both clinical and endoscopic remission. I find the endoscopic results the most impressive. Endoscopic response and remission occurs later for Crohn's disease than ulcerative colitis and is harder to achieve. You know, they did get a very nice low placebo response rate here, which made it highly statistically significant with drug. This was a pretty tough cohort too. Nearly 2/3 of patients had failed 2 or more biologics, a third were on steroids at baseline. Then the second question you've got to ask with any drug is how quickly does it work? And the JAK inhibitors work quickly. You can see here, if we look at the bottom, we're seeing clinical response as early as week 2 and clinical remission as early as week 4 with this agent. These are just induction data. We look forward to the maintenance data, but they are very encouraging, especially the endoscopic data. Let's move on now to another molecule that we hope to have, which is filgotinib. Filgotinib is a drug that was developed by the company Gilead, has now been taken over by a new company in the IBD space called Galapagos. This is, again, it's a JAK1 selective inhibitor that is being trialled in ulcerative colitis and Crohn's disease. The program is called Selection. What we're looking at here is the ulcerative colitis data, and the question of this analysis is, what about retreatment and is it effective? So this was a program where patients were randomized 2-to-1 to drug or placebo. Responders, and the doses there were 200 milligrams or 100 milligrams of filgotinib. Responders were then re-randomized to either drug or placebo. So this was by definition a withdrawal study. You could get placebo in maintenance, but if patients flared, they had the option of being treated with 200 milligrams of filgotinib. So these are patients who got drug, flared on placebo and were retreated. In the program, this analysis was done on 85 patients all up. Median time to flaring in maintenance was about 4 months or so, but we can see response at 6 months with retreatment was about 40 to 45% overall, so pretty good. And you can see the top right there, the graphs coming down, the response was the same, whether they got the initial dose of 200 or 100. In the long-term extension overall, those rates that I said were remission rates in the order of 40 to 45%, even higher for response. So the message here is, in any small molecule, but in JAKs here, is we can retreat with encouraging results. Filgotinib's a therapy that's had some issues as it's moved through regulatory processes, but we do hope it'll be available for us, you know, perhaps even within the next 12 months. If we look here at Ozanimod, Ozanimod will probably be the first small molecule that we have. Ozanimod is an S1P modulator. This is a drug that is on the market for MS. and will be both, it's approved it's registered for use here and should be PBS reimbursed, perhaps by the end of the year, maybe a little bit later. This drug works effectively by trapping lymphocytes within lymphoid tissues, including lymph nodes, stopping them getting to the vasculature and therefore the bowel wall. The program in ulcerative colitis is called True North. Again, a 2-to-1 randomization of drug to placebo, clinical response at week 10. The question here, similar to what we showed with abatacitinib, is what do you do in non-responders at week 10? Do you treat for longer? I think these results would suggest yes. We can see in this analysis of non-responders at week 10, there was 150 patients who were treated, and again, almost half of them, 49%, responded to a further 10 weeks of treatment, and the majority had responded by week 5. So that's the message from on the left. The issue, as I said, with small molecules is really more about safety. Safety signals tend to come out in maintenance trials and then open label extensions and post-marketing surveillance. So what this was looking at was the safety data through the open label extension, which was 2 years or 94 weeks, almost 2 years beyond the trial, which itself was a year. So we're now getting out to 3 years of drug exposure versus, as I said earlier and showed with tofacitinib, we're almost out to 8 years. But this was looking at the safety analyses and also efficacy. No new safety signals were developed that were demonstrated with time, which is reassuring. There are some novel safety aspects this drug will need to understand, and we'll present that fairly soon. There was a drop-off with time in the open label extension, but 2 years out in extension, i.e. 3 years of trial, 55% of patients were responding. This loss of response with time does appear to be less with a small molecule than a biologic. So some encouraging data here. I think it's going to be the safety things that we'll need to manage in the logistics with this class of therapy when it's available, hopefully sooner rather than later. Again, from the same molecule, Ozanimod, and retreatment, and this is from the same cohort. I'll move through this fairly quickly, but again, these are patients. This was the maintenance phase of this study, was a randomized responder study where patients could be randomized to placebo. Those that flared were then treated with open label drug. In this analysis, that was 77 patients. The mean time to flaring in maintenance was about 2 months. And you can see the response, again, was about 55 to 60% to retreatment, excuse me, with this agent. Most patients are responding by week 5, and then some taking out to 10 weeks. Again, a small molecule, we can retreat and be successful in over half our patients, which is encouraging. I think what this is going to be interesting, there'll be, whereas biologics are agents that we generally continue until there's a reason not to, there will be a little more flexibility with small molecules in being able to stop and start therapy. Important decisions, we've got to do that appropriately. The final small molecule is Ozanimod. Ozanimod it's another S1P modulator. This blocks, modulates rather, the receptors S1P1, 4, and 5. Ozanimod is just 1 and 5. We included this, even though this is a little bit further away from the clinic for us and won't be imminently available. This is a very well-designed phase 3 study that is a positive study with both an induction and maintenance. The dose here of Ozanimod is 2 milligrams. With Ozanimod, it's 1 milligram. This is, again, it's a daily dose. The S1P is a daily dose. Some of the JAKs, tofacitinib that we have, are a twice daily dose. You can see here, this is, if we look at over on the left, the efficacy endpoints at week 12, standard ulcerative colitis endpoints, significantly better results with drug versus placebo for the primary endpoint of clinical remission, and secondary endpoints, which included mucosal healing, which includes histology, which was a pre-specified secondary endpoint, and then as it is increasingly becoming appropriately in ulcerative colitis trials. And then if we look over to the right, we're looking at the maintenance data here. Again, really nice results, drug versus placebo, both primary and secondary endpoints, including mucosal, or I think a better term is endoscopic healing. One of the practical things with this drug, with Ozanimod, for the first week of therapy. Patients have a gradual dose escalation to get up to the 1 milligram daily dose to minimize bradycardia. That is not necessary with this molecule, Ozanimod, so that will make it a little simpler. It's a fair bit further away from the clinic for us, but these are encouraging data. So let's finish this section on some non-small molecule data, but some dietary therapy. So the Crohn's disease exclusion diet, which was published by Ari Levine's group a couple of years ago, got a lot of press, and patients are very interested in dietary therapies. This is a diet that is a whole food diet designed to target the gut microbiome and intestinal immunity. These are some data on real-world use. This is an interesting diet in that it's not only an exclusion diet of things you can't eat, it's actually there are things that you have to eat as well. And there's a high amount of protein, especially chicken and eggs within the diet. And in presenting this data set, previously at a couple of sites, some of the academic dietitians have said actually their patients find it hard to eat and perhaps even afford the amount of protein that's necessary in this diet. But look, what we need is some real world data to see if we can replicate what's been seen in clinical trials. These are further Israeli data from different centre in Tel Aviv. This is a Crohn's disease study, just a retrospective analysis of the Crohn's disease exclusion diet. This is a dietary study. It's an induction study, so they're looking at week 12 results. It's predominantly clinical endpoints, Harvey-Bradshaw index. There are some data on calprotectin. So this was 100 patients, of which about 75 patients had active disease at the initiation of therapy. An important point that this wasn't the sole dietary therapy in the majority of patients. It was in 40% of patients, but in the remainder it was a bridge to biologics or it was used with another therapy. And similarly, adherence was variable, and only just over half of patients were able to be highly adherent to this diet. You know, remembering that there does seem to be some practical difficulties with implementing the diet, but overall it worked. Nearly 2/3 of patients in clinical remission at week 12. If we go to the results up at top right, we can see on the left, there's the Harvey-Bradshaw, a nice drop, and then also a drop in calprotectin. Always important to see objective outcomes. You can see at the bottom here, the improvements were greatest in patients with high dietary adherence. This has got all of the flaws of a retrospective single centre study, of course, but I think our patients are interested in dietary therapy. And, you know, these are encouraging data for us. Finishing on some nutritional therapy and enteral nutrition, used here in the concept of trying to optimize nutrition prior to surgery in Crohn's disease patients, rather than in the form of exclusive enteral nutrition as a therapy in itself. These data replicate data that Neil Hirasingh produced at Exeter a couple of years back, but this is a bigger series. This is from St Thomas's in London. This is a very big IBD centre, and it's a large series of actually 300 surgical procedures, and they looked at the outcomes of patients who were nutritionally optimized with nutritional therapy, which is defined as receiving at least 2 weeks of nutritional therapy preoperatively, versus those that weren't. This was over a long period of over a decade. The primary endpoint was 30-day post-operative complications, a number of secondary endpoints. So 300 procedures, about 1/3 of which didn't receive any nutritional optimization, 2/3 did. Those that did actually received it for out to 55 days, so a long period. And you can see overall post-op complications were significantly lower in those that received nutritional optimization, both overall, surgical and non-surgical and infective complications. You can see at the top right, this is a pretty tough cohort. A lot of patients on biologics, immunomodulators, thankfully not a lot of steroid use. There were biochemical improvements that were visible as well, with an increase in albumin and a reduction in CRP. I think the message here is, you know, look, what's to lose with nutritional optimization? The one thing that you know, we all need is the dietetic support and services and being able to afford this for our patients. But I think this is something that we really all should be paying probably more attention to than we are. So that's the end of that section. Let's have a look. We've got some questions coming in. Alrighty. From Lauren. Are there data, subgroup analyses, or standalone studies looking at TOFA or other small molecules specifically in ulcerative proctitis? That's a question from Lauren Beswick from Geelong. Hi, Lauren. Lauren, there's not dedicated studies in ulcerative proctitis, which is really unfair. It's such a tough beast to treat. But there are post-hoc analyses from the initial Octave studies with TOFA, which do show equal efficacy in left-sided colitis to extensive colitis. Unfortunately, as with most clinical trials, isolated proctitis was excluded. So I don't think we really know that exact answer, but certainly left-sided versus extensive seems to be the same response, Lauren. We've got a question from Astrid Williams from Sydney. Astrid's asking, is there a theoretical or demonstrated concern that S1P agonists are unlikely to be as effective in VIDO non-responders, given both have a lymphocyte trafficking mechanism of action? Would this influence your positioning of use? Yeah, it's a great question, Astrid. I can't answer it, but I think theoretically there is a possibility these have a similar mechanism of action of essentially lymphocyte depletion. If VIDO didn't work, then you would have to think, is this an S1P modulator going to work? I think modulator is a better term, Astrid, than agonist, as you said here. The other comment that I would make here is, you know, the non-selective adhesion molecule inhibitors, and obviously natalizumab, there was obviously an issue with PML. I think as a class that is a theoretical possibility with S1P. It has been, I believe, and look, I may be wrong here, but I believe there has been one case with Ozanimod, but they had prolonged periods of other immunosuppressive agents as well. It has been an issue with Galenia, one of the MS S1P modulators. Hopefully this doesn't become a big problem, but that's, and I don't think it will, but that's a really interesting question, Astrid, that you pose about VIDO non-responders. Perhaps this drug mightn't work well. There's a question from Wayland Dianella. In a real-world pandemic application, logistics-based infusion centres is becoming more scarce and competitive. From a logistic standpoint, will small molecules eventually position higher than standard IV and subcut? That's a great question. I think as much as we try and be evidence-based and scientific about all our therapies, our choice, our positioning, practicalities matter. It is a hell of a lot easier to write a prescription for a small molecule than a biologic. And for clinicians, it's easier. For patients, it's easier to take. I think there will be a proportion of patients that will choose a small molecule, acknowledging the side effects just for ease. I think we've got to put that in perspective and not be, I think our decision should primarily be based scientifically on safety and efficacy, but I think the small molecules, the place of them, I think they will increase progressively, and they'll be a really big player in our field in the next couple of years. As I mentioned, we may even have 3 of them. And look, yeah, the subcuts are really the data for the subcut biologics in infliximab, which we'll see tomorrow, are looking really encouraging. I think anything that's practical when you've got time poor and labour intensive and labour heavy clinicians are going to be popular. Then there is just Tuan Dong's got 2 questions. I might just answer one. With retreatment with Ozanimod, do you uptitrate the dosing again? Yeah, the answer is yes. If patients have a gap of therapy of anything, I believe it's even longer than a week, which is going to be everyone who's stopped it, then you do need to go through this up titration over a 1-week period. That's my understanding, not something that I've had personal experience with yet, Tuan. I'm mindful of time, and I know there was a couple of other questions. Please try and send them in and I'll see if I can get to them. Just going to get on to our other sections for today. So we've got safety, and then we've got psychosocial. So I think there's about 7 or 8 slides and studies to come. We'll probably finish just after 8 or between 8 and 8:15, I think, guys. So as I mentioned earlier, the issue with Ozanimod that gastroenterologists will need to be familiar with is the cardiovascular side effect potential, and in particular bradycardia. In the phase 2 dose finding studies for this molecule, bradycardia was seen in the dose that we've got, which is 1 milligram, which interestingly is actually 0.92 milligrams of drug, and then the rest's hydrochloride that it's bound to. The bradycardia occurs, but it doesn't seem to be a big problem. And this dose was chosen predominantly for that reason. So these analyses, again, we need as many patients in studies and data for analyses for safety questions as we can. So this analysis, which was just a post-hoc analysis, but Susie and I included it because it's a new molecule we're going to have. This was looking at data from the True North development program in ulcerative colitis and also MS data from their trial program that are called Sunbeam and Radiant. So there's 3 studies together. We do need to know that patients with significant bradycardia or active cardiovascular disease, predominantly significant coronary artery disease or unstable coronary disease or severe heart failure, were excluded from these studies. We've got a follow-up of a year for this analysis for ulcerative colitis and 2 years for multiple sclerosis. Overall, these data are encouraging and reassuring for us. There was so there's 520 patients in this analysis. The mean reduction in heart rate was 1 beat per minute in the ulcerative colitis studies and 1.2 in the MS studies. You can see also in the table here on the right, other cardiovascular side effects were very rare in ulcerative colitis, slightly higher in the MS studies. Perhaps that just reflects bigger numbers and longer follow-up. But overall, serious cardiovascular events are very low. There were no clinically significant hypertension in these analyses. Mechanistically, there is a risk of hypertension with this drug, and there has been a recent case report from the University of Chicago of a patient who had a hypertensive crisis that responded to treatment. There was no mortality from cardiovascular events in these studies, nor treatment discontinuation was very low. So I think this is something that gastroenterologists, we're going to have to be comfortable with, which is, how do we order an ECG? How do we read it? Do we get our cardiology colleagues, phone a friend to read it? And then, how do we position, frame this to patients who are all of a sudden coming into a gastroenterology clinic and getting an ECG? I think these data are largely encouraging. This will just be a logistic thing that we need to get our heads around, which I'm sure we can. If we look at some other safety issues, and we included this even though it's really not new or novel, but perhaps it's something that we thought was we're overlooking, and certainly I feel sometimes we are at the Alfred. So this is this issue of PJP, or previously PCP, with immunosuppression. And this is a large analysis of a Korean insurance database. Huge numbers here, nearly 40,000 IBD patients, of which they had 84 cases of PJP. The take-home message here is that it's the patients, we can see at the table on the right in their multivariate analysis at the bottom, it's the patients on triple immunosuppressive therapy that are at the highest risk here. That reached significance for both ulcerative colitis and Crohn's disease. Dual therapy only reached significance for ulcerative colitis. I guess in clinical practice, the patient that I would think of and maybe admit that I'd been forgetting to use Bactrim prophylaxis here is the patient that is an ulcerative colitis patient that comes in on azathioprine with acute severe UC, that gets IV steroids, doesn't respond, and gets infliximab, and then is bridged to that as an outpatient. That patient's going home on triple immunosuppression. We should be thinking of Bactrim prophylaxis in that patient. For whatever reason, we tend to do it with cyclosporin, but haven't been so much in patients that have received infliximab. These data would suggest that we should. Bactrim's a drug that's not without its own drugs, its own side effects, but I think risk overall relatively low. Importantly and inevitably, some COVID data. There's so much at the meeting, we chose to just focus on a couple of things, and we've really just focused on this relevant question of how do our patients on immunosuppressive therapies respond to vaccination. You can see here the table on the right summarizes responses and where we see an attenuated response, and this does seem to be a problem to 2 vaccinations. So if patients have received just 2 COVID vaccinations, thankfully most of ours will be well and truly beyond this third or even fourth and some even fifth now. But patients who receive 2 COVID vaccinations, those on corticosteroids, especially at doses greater than 20 milligrams, anti-TNFs in combination with thiopurines or tofacitinib had a suboptimal serological conversion and response. You can see here ustekinumab. Actually, the Alexander study is a UK study. There was a slightly lower response with Stelara. Most other studies haven't shown that. I don't think that's a big issue. So I think that drugs that are highlighted in bold there are the ones that we do need to make sure our patients are fully vaccinated, 3 or ideally 4 doses. The message here is, vaccinate with 3 doses and you do well. We've got 3 different analyses here. There's a proliferation of research. I must admit, I found it quite inspiring how quickly centres have flipped into doing research on COVID and producing really high quality registers. I'll just go through the take-home messages on each of these 3 studies. The left-hand study is a Canadian study looking at conversion in 2 versus 3 doses, 94% 2 doses, 100% with the 3rd dose. The middle study is another registry called Prevent from Chapel Hill, which has been active in this area. You can see again 93% seroconversion to 2 doses, 99.5 to 3. What was important here was that of 47 patients that didn't get a response to 2 doses, 45 did with a 3rd. Highest responses seen with the Moderna mRNA vaccine. And then reassuring safety data from the Corral registry that's over on the right, which is based out of Cedars-Sinai in LA. There was this issue of patients getting fearful of side effects to vaccination, maybe especially with the 2nd dose. You can see here that side effects with the 3rd dose seem to be less than with the 2nd dose is the take-home message, reassuring for our patients. I mean, these data, this field is moving so fast, it's really, what we need to know is what about 4th and subsequent doses, but the message here is obviously to vaccinate our patients, and especially in those on steroids greater than, we should try and get their prednisolone dose down to less than 20 milligrams, perhaps ideally less than 10, and it's the patients on anti-TNF monotherapy, anti-TNF thiopurine combination or TOFA that really do need full vaccination. That's the end of the safety section. I'll just see whether we've got any new questions. So there's a question here from Lei Gan. My understanding is subcutaneous infliximab has a steady level, so we can check it anytime. Look, I'll be brief here because we'll go through that study in detail tomorrow. But yeah, with subcutaneous infliximab, the levels overall are higher. What's important though is the overall drug exposure, which is best measured by area under the curve, and that is slightly higher, but it's not as dramatically higher as the numerical difference, which I'll really go into a bit of detail on tomorrow. But yeah, Xavier Roblin from France has done a very nice study where he showed that you can measure the level at any time in a 14-day cycle. Don't need to go to trough. So that's a nice practical advantage to subcutaneous infliximab. There's getting back to a question from Tuan Dong back about tofacitinib. With tofacitinib, any safety data with melanoma? Are you happy to start it when someone with melanoma 12 months ago completely resected? I'm not aware of any safety data, Tuan, with melanoma. There is a slight signal with non-melanoma skin cancers with tofacitinib, as there is, we know, certainly with thiopurines, but I'm not aware of a signal with melanoma. In answer to your patient, look, I'd certainly be speaking with oncology colleagues. My guess is that they would be happy of that. They're usually pretty gung-ho with cracking on with therapies in someone who's had a completely resected melanoma, especially if it was a superficial lesion. We're just going to finish here with some quality of life and 3 studies here, all with some similar themes. There's 2 that are based on this CONFIDE study, which is a web-based survey study run in the US and in Europe. This is an ulcerative colitis survey, and it's based about the questions they're asking ulcerative colitis patients are, what are the symptoms that really matter to you? We've got to bear in mind that the patient-reported outcomes, or PRO symptoms used for ulcerative colitis in clinical trials, are bowel frequency and rectal bleeding. But what really matters to patients? So this was a survey where they actually asked 200 UC patients with moderate severe disease and also 200 gastroenterologists that treat these patients. What do they think are the most important symptoms? The message here is urgency is really highly feared as a symptom by patients, and it was the second most commonly reported symptom by patients, but it was not by gastroenterologists. And in fact, less than a quarter of gastroenterologists rated urgency in the top 3 symptoms. You know, you can see the other symptoms: diarrhea, increased frequency. Interestingly, rectal bleeding doesn't get in here. I think the urgency, the patients just really struggle with it. That fear of being away from the bathroom, that fear of leaving the home, especially in the morning. What has happened is there is a move to get urgency as a pre-specified secondary endpoint in ulcerative colitis clinical trials. I'll show you some data on that with mirikizumab tomorrow. I think that's a great idea. I think urgency is something we've really got to be asking our patients about. And this does show a bit of a discord in what we think is important versus what our patients do. From the same survey, and just asking the patients here about sexual activity in ulcerative colitis and what affects it, I think we tend to think maybe about the reduction in sexual activity in Crohn's disease, especially perianal Crohn's disease. These data would suggest that we really should think about it in ulcerative colitis patients as well. So this is that same 200 cohort of 200 patients in their online survey, and the results were that more than 3/4 of women and more than 50% of men reported avoiding or decreasing sexual activity due to their ulcerative colitis. And the top 3 reasons were the same between the sexes, and 2 out of 3 related to urgency: bowel urgency, fear of urgency-related accidents, and decreased sexual desire. I think we need to think about sexual health in our ulcerative colitis patients equally as we do in our Crohn's patients, as this would suggest. And then finishing with some sexual health data in males. We've long been aware of the reduced fecundity, or the ability of women to conceive after ileoanal pouch surgery. I think there's about a 50% reduction in fecundity. Thankfully, most women can still conceive after pouch surgery. It can just take longer. The question here, and this was an analysis out of the Explorers database, which is analysed by the Cleveland group predominantly, was, well, what about males who've had pouch surgery and sexual dysfunction? They define sexual dysfunction as erectile dysfunction or an ejaculatory disorder that required a Viagra-type medication. Presumably, that's how they did their search in the database. Huge numbers here. I mean, this is amazing. 41,000 pouches in the US that were researched. Male sexual dysfunction was more common in patients with pouches versus those without. And after they controlled for other risk factors, pouch patients was independently associated with sexual dysfunction, almost an odds ratio of almost double. You can see in terms of the risk factors, but if it's particularly the obvious ones of age and vascular risk factors, coronary disease, diabetes, the mental health ones, hypertension, but actually anti-TNF use, presumably as a surrogate for active disease, was a risk factor as well. No details here on laparoscopic versus open, or in comparing sexual dysfunction in males with a pouch versus an endometriostomy, which is another very relevant question. I think the message here is that, you know, we need to talk about this risk in males in the same way that we do in females. Thanks very much, everyone. Bye-bye now.